and welcome. This is a series called Understanding Depression, Hope Through Treatment. I'm Mary Hanson. I'm a social worker and the host of a long-running public television and cable show that has focused for years on health and social issues. My co-host is Dr. James Jordan. Dr. Jordan is a psychiatrist. You are the past president of the Minnesota Psychiatric Society, Jim, and the past medical director at the Ham Psychiatric Clinic in St. Paul, Minnesota. And Dr. Jordan was there for 25 years.
We're going to talk to you about a common and treatable public health problem, depression. Our series and the interviews in the series give you an opportunity to see the manifestations of depression through the life cycle. We believe that there are critical things for you to understand and take with you in order to be able to take care of yourself, members of your family, your coworkers, for this very common health problem.
In this next segment, Dr. Jordan will introduce you to Dr. Patrcia Lindholm, who happens to be the president of the Minnesota Medical Association. She's going to talk about her experience dealing with major depression, as well as her professional experience and take on dealing with patients with depression. Please stay with us.
My guest today is Dr. Patrcia Lindholm. Dr. Lindholm is a family doctor from Fergus Falls, Minnesota. She's a colleague of mine, and she's also the president of the Minnesota Medical Association. We're going to have a conversation about depression, treatment of depression, and the hope that lies in the proper treatment of this common condition. Welcome, Dr. Lindholm.
Thank you.
Can you talk to me, tell us about your experience with depression as a physician?
As a physician, I have been not only involved in patient care, but also I've been active in my organizations. And I have a tendency to get over-involved and to be very prone to burning out because of my over-involvement. And several years ago, I was in that situation again, where I felt that I was starting to get, it was more and more difficult to get up in the morning, more and more difficult to go to work. It is a cycle that I have been through before, but has been worse during my career as a physician.
Now, when this became part of your life, it emerged in your life, what were the steps you took to get help as a doctor?
As a doctor, early in my career, I was afraid to talk about it. I was afraid to let anybody know that I had depression, and therefore started medicating myself, since as a doctor I had a lot of access to samples of medications, including antidepressants, and got by for a little while doing that, and it was like a window dressing. I was able to look like everything was fine and able to get through my days. Over the last several years, it progressed, and I realized that it was beyond me to treat this, and I needed to have some professional help. I started seeing a psychiatrist. Actually, over the years, I'd seen psychiatrists several times, but in the last several years had a very, very serious depression and needed a lot more intensive treatment.
May I ask you a question about that particular turning point where you were a doctor who was doing her best to take care of herself, but then you turned to professional help. Can you tell us what was the thing that facilitated that?
Well, several things. I think one is that I realized what I was doing wasn't working. But also, people became concerned. There were one or two people who could sense that something was going on with me, and a friend who happens to be our hospital chaplain, he and I worked together on a number of projects, and he became concerned when I stepped down from an important board that I was sitting on and wondered what was happening. And we had a frank talk, and actually by that time I was already getting psychiatric care, but it started to get to the point where I really needed the best care. And I needed to get over the embarrassment and the, I needed to just be frank about my issues. And doctors can easily get informal care, as you know, from our colleagues, and it may not go on any official records. Well, I insisted that this go in my official records, that it go in my chart, because I wanted, for the future, people to understand the treatment that I'd had, the problems that I had, what had been tried and what hadn't been tried, because it's not good. I concluded that it's not good to get unofficial, undocumented care. I was referred by my psychiatrist also to a therapist who happens to be a psychologist, and those two have been working with me very intensely for 3 or 4 years now.
Psychotherapy now.
Psychotherapy.
Right? So we have this turning point, you enter into care and treatment, and you're also learning about something that has to do with physicians, their day-to-day life, stress, how they're managed this. Tell us about the treatment. How did that unfold?
My treatment, I was, of course, I already on some medication when I went to my psychiatrist, and had already maximized the dosing, and we talked about things that I had done and taken in the past, and he came up with a plan. The treatment, you know, I'm used to thinking that it takes 2 to 4 to 6 weeks for an antidepressant to start working, and in my past experience that was about right. This time it took about a year to get better. It took about a year for the medications to be adjusted in such a way that I could take them without side effects that were bothersome, and also get some relief. And by the time the medications were all adjusted and chosen and seemed to work together well, I was on 3 medications and still am.
So tailoring and adjusting the medication was an important part of helping you feel better, and gradually over a period of months,
Yes.
not days or weeks or hours.
Right.
So not a quick response, but we're starting to see some improvement.
Absolutely.
And the therapy is going on in
the meantime,
parallel to this.
Yes. And I think that both the medication and the therapy were absolutely crucial this time. And I really feel that they saved my life. They saved my life. There's no doubt about it. And as I've told some of my colleagues, you know, the psychiatrists and other mental health practitioners don't get the credit that the life-saving teams in the emergency room get, or the people with the defibrillators and so forth. But I was in more danger from depression than anything I'd ever experienced.
Let's talk about that in terms of that particular signal or sign or symptom, your life, your feelings about your life. You were feeling like life wasn't worth living?
Exactly. I was feeling hopeless. I couldn't see the point in continuing, and I felt like there was this almost physical pain weighing on my heart, physical pain in the chest, almost a crushing sensation. I knew it was from depression. I wasn't worried about my heart or anything like that, but it was incapacitating. I knew that if I didn't get help, I didn't have much time left. I was in the worst state I'd ever been, and I had had other suicidal feelings in the past, but this time it didn't matter that I was a physician. There are other physicians. Didn't matter that I was a mother. My children were grown up. I'm sure my husband is grown up enough to get by without me. I had no reason that I could see to continue living.
Yes. Gradually, as you were in treatment, therapy, and taking medications, they were being adjusted and so forth, you began to feel better and better.
Yes.
And as that moved ahead, if we look at it today, where has this taken you, this journey through your treatment, and how you're feeling today and your understanding of this?
Well, it has been an education for me for sure, not only that physicians shouldn't treat themselves, but also a better understanding of my own patients and my own family members, but a better understanding of myself and the fact that I have, in my case, a chronic illness that can't be ignored and needs to be treated. I started to study the problem in physicians in particular and how prone we are to burnout, to losing our purpose, to working so hard that we lose sight of the big picture in our lives, and learned that physicians have a very high death rate from suicide compared to the general population with depression, and that female physicians in particular are 4 times more likely to take our lives than other females in other professions. And I have to credit my psychologist for getting interested in the subject and sharing some articles with me, which then stimulated my own research, and I just had a desire to help my colleagues, to help others. So as you know, I'm now the president of the Medical Association, which I did not seek out, but I was invited to do, and I saw it as an opportunity to work on the wellness of physicians.
And this is where we met.
That's right.
You invited me to be a member of your task force. Extremely important in the area of doctor take care of oneself.
Exactly.
Be a good example for your patients. And then more and more women in our profession who have certain vulnerabilities to depression in that context of their lives and their other responsibilities and so forth. How do you see the future now as far as family practice, psychiatry, social work, psychology, working with psychologists? Is there something for us to understand about working together, learning from each other, learning from psychology, psychiatry, communicating with social work, this type of thing?
I would love to see us all work in the same clinic. Ideally, it would be wonderful if down the hall I had a psychiatrist to talk to, a psychologist and a social worker, all of these people who would be available as a team to help me with my patients, because every one of them are critical. And right now it's difficult because people are across town or they're out of town, they're in separate buildings. And I like the model that I've heard about where we're trying to integrate mental health professionals into general medical care. I think mental health care is not separate from the rest of medical care. I know that the mind and the body are one and they affect each other, and there's no point in pretending that they are separate disciplines or that mental health isn't the same as heart disease, cancer, or any other life-threatening condition.
And very treatable.
And very treatable.
It might take some time. There's some complexities. The complexities need to be addressed if they're in the psychological realm or one's environment, stress at work. There can be biological factors. You pointed out you had a very profound physical sense of what this meant to be depressed.
Yes.
You know, a crushing feeling.
Yes.
And so that can be a marker of someone feeling better as medication is helping, they're starting to feel better. Then the therapy can move ahead.
Exactly.
Make some progress in that realm.
And the fact that 2 professionals were spending time with me gave me hope. And I think hope, even before feeling better, was the key to sticking with it.
Dr. Lynn Home, I want to thank you so much. When we started this project, it was really just a gift to have the opportunity to know more about you, to have you help us with this endeavor. And we believe that in the context of treating a treatable condition like depression, really talking and understanding is in conversation. So we have more of these conversations. A consultation is a conversation between colleagues, all involved in this, the team effort. Thank you so much again. We'll be back to talk to you more about depression, Mary Hanson and I. Thank you very much, and thanks to Dr. Lynn Home for talking with me about this topic today.
many of you are probably surprised, a way I am too, that a doctor will talk this openly as Dr. Lynn Home has about her experience with major depression. I think we somehow put doctors on pedestals yet. And her experience, though, was quite serious. She was very honest. What did you take away from your time with her?
Well, in the case of Dr. Lynn Home and any professional person, we're talking about physician here, first of all, these are human beings. They get up in the morning just like you and I do. They have lives, they have needs, they are exposed to the stresses of their work, the workplace. Often you see in positions of leadership, a physician in his or her office are taking care of a lot of responsibility that can be weighing on them, that can be a strain or a stress or stressors. And I think everyone's aware that during this period of time that we're in now, there's lots of stress on physicians in terms of how much work they have to do, the electronic medical record, the demands of coverage at a hospital and back to the practice. These are human beings. So to the extent that they can be helped, as all of us would like to be helped in the workplace, this is their workplace, the practice of medicine, then we can make sure that they do the things that they need to do to prevent the onset of depression. And in the case of Dr. Lynn Home, I think she pointed out how her care now is very well established and she's doing well. She's in a leadership position.
She's also a good role model for her patients, I would think, if they see this interview or talk with her about her experience. That's an example of taking care of yourself that I'm sure would translate impressively to her patients. She talked, Jim, about something that was so vivid as she stated it. She said, I felt like I had a crushing pain in my chest. And this was one of her symptoms of depression. Right. And yet, this really struck me as something that could be so easily thought heart problems. When you heard that, did you feel that was a common reaction to major depression?
You can, in the case of Dr. Lynn Home and describing it that way, have a somatic manifestation of major depression. And as you say, I mean, that's important to make the distinction between something that could very well be a physical problem, coronary artery disease or pressure in the chest and so forth. So a good, thorough physical examination would be important step one if someone presented with a complaint like that. However, the nature of it combined with other aspects of her life, excluding a physical cause, it certainly can be. And as people get older, midlife and on, you do often see these correlates with the manifestations of depression with physical complaints, headaches, backaches, chest pain. Pain is worse than it should be for a certain condition. So these are the kinds of things that physicians pay attention to. And in this case, you have a physician who is able to describe in very vivid terms, how this really gets into the body and expresses itself that way.
I think if someone hasn't experienced serious depression, they maybe would assume it was all an emotional, mental, kind of reactive experience. And yet people who have experienced it do describe it as a very whole body kind of pain and discomfort.
Yeah. Absolutely. I mean, it will, in the early phase, can be an emotional manifestation, sadness and worry, anxiety, obsessive thinking and so forth. But as it advances, you start to see the physical disruption, the effect on sleep, appetite, just how you feel physically, energy, listless, not able to do what you need to do. Parents are unable to take care of their children properly You can see the effect that this is going to have
Things
on a
start
family.
falling through the cracks.
That's right.
We have now in our country a new law called the Parity Act. And could you just briefly define it, because it's going to make a big difference, hopefully, in the way people access care to their physician, to get diagnosed, to mental health professionals.
We're very proud of this here in Minnesota. Paul Wellstone and others, Jim Ramstead and many others have helped move this concept, this idea that mental health care has to be equivalent to the treatment of any other health condition. And without getting into the technical aspects of the law now is a federal law that a mental health condition, like major depression, has to be treated on a par basis with diabetes, heart disease. In other words, all of the expectations that we would have for appropriate evaluation and treatment are the same for treatment of mental health conditions and serious ones like major depression, just like any other health problem.
That is such a forward and finally wonderful law, isn't it? I want to go back to something Dr. Lynn Home said. She really said that she considers herself having a chronic illness. Do you feel that most depression is going to kind of ebb and flow? Are people going to have reoccurrences usually or occasionally?
Well, it's an important distinction to make in terms of chronic or recurrent. Yes, there's a percentage of people that will have a recurrence of a major depressive episode. One of the things that's most important in terms of that possibility is to get early treatment and to have sustained and good treatment, just like Dr. Lynn Home describes, a combination of medication and effective psychotherapy so that she manages her condition as well as possible. Yes, it can be recurrent, but also there can be a single episode, and that can be it. So we want to treat someone effectively. The treatment usually transpires over a period of months, close monitoring, and then judicious use of medication combined with psychotherapy, reassess the patient, so evaluation at the front end, reevaluation as you go along. These are the components of good practices, and this is the kind of thing that can help, in this case, a physician get the care that she needs. And as you said, also by having the experience with this condition, how sensitive, how thoughtful, how empathic she can be with her own patients as a leader now in understanding this and the stress of physicians in Minnesota. This is her initiative with the Minnesota Medical Association.
Really, her story really speaks to the necessity to take care of ourselves, whether we're in the health system or not, doesn't it? She really struggled, she said almost a year, I believe, to come up with her doctors the correct and proper kind of med regime. And I know our first guest also said that she struggled with meds in that way and didn't really ever find them effective. But Dr. Lindholm is now on, she said, 3 meds. Is that common to be on several meds?
Yes, it can be for recurrent depression, and the combination of medication is something you get to. I think at the outset often, and good practice is you start with one medication, stabilize the patient in terms of the major depressive signs and symptoms. But often that medication may not be working effectively and you need to add something else to it. And so there are combinations of medication. But once again, this should be done very, very thoughtfully, closely supervised. And I really think this is where a psychiatric consultation and very close management of the mix of medications, because you get multiple side effects. These drugs potentiate the effect of each other. And so it becomes a technical management question. And I think this is really the role of psychiatry and psychiatric consultation, when someone is not responding to that first trial of medication and they're needing multiple medications to maintain their stability in remission.
Dr. Lindholm talked about her role as a primary physician, and in our healthcare system now, the primary doc is often, as I think you said once, Jim, the entryway to being treated for depression. Mm-hmm. And people probably most often, am I right, go to the primary doctor mm-hmm. for a diagnosis. And do you feel that in just a few seconds there is the best place to go first?
It probably is, and if we're talking about major depression, because you're going to get a good and thorough physical examination to exclude any physical basis for the way that you're feeling. And then, and we're particularly interested in this in Minnesota, we have screening going on now across the state, looking for depression, early treatment. So yes, that's the first portal of entry. We recommend it because of the thoroughness of it, and then it's a good platform to stand on for further treatment and referral.
Well, we are covering things quickly here, but next week we will talk more about treatment. Jim will also introduce you to another person who is dealing with major depression. Thank you for being with us. We want to thank everyone who has been a part of the preparation for this show, KSTP and our underwriters. We'll see you hopefully next week. If you or someone you know is dealing with depression and needs help right now, call 911. If you want to know where to go in your area for an assessment and or for treatment, you may call 211. This number can connect you to mental health resources throughout the United States.